This is Laura McGann. I'm the co-host of Bad Takes, and I'm here with Matthew Iglesias. Hey, Matt, how's it going?
It's going great. It's going great,
Good. I actually have a bad take this week. Should I dive right in?
Wow, it's a rare week that anyone has done a take that's bad.
I know. Wow. It's really tough on the internet to find a bad take these days. Only good takes.
I'm wondering how long this show can last. No, what do we have? What's cooking?
There's been some reporting in recent weeks that the American Academy of Pediatrics has issued some new guidelines for treating obesity amongst American children. This is very sadly a big problem for children in the United States. The Pediatric Academy is saying that 14 million children and adolescents suffer from obesity in the United States, which is a startling high number. It's grown over recent years and decades, and there's no sign of this trend stopping. So they released a report. It's about 75 pages long. And in it, it includes a number of recommendations for pediatricians who see children who are obese and how to handle it. So that's the context here. The bad take I want to raise today is in the New York Times opinion section. And the title is Why the New Obesity Guidelines for Kids Terrify Me. This is a piece from Virginia Soule-Smith. She has written on the culture of dieting and the culture of sort of cultural attitudes towards obesity and fatness in the United States. And largely, I would characterize her as a kind of leading writer and thinker on the anti-fat movement. And she writes in her paper that she sees these new guidelines as simply confirming the attitudes that are a problem in our society, that stigmatizes obesity, stigmatizes being overweight. And she doubts that the new guidelines will actually help children. Specifically, she's calling out suggestions in the guidelines to consider weight loss medication, and in adolescents who are very far along in their obesity, who are extremely obese, referring adolescents and their parents to bariatric surgery centers to be evaluated. So she concludes her piece saying that we cannot solve anti-fat bias by making fat kids thin. Our current approach only teaches them that trusted adults believe the bullies are right, that a fat body is just a problem to solve. That's not where the conversation about anyone's health should begin.
Well, so we've talked about this before, broadly speaking. This comes from a school of thought, which I think holds that the only problem with being overweight is that there is stigma associated with it, right? I mean, this is a kind of a diagnostic lens that takes the toolkit, right? That, coming out of like post-World War II America, you start to see the beginnings of a culture that tells people, we shouldn't be prejudiced based on national origin, based on religion. We have a first Catholic president. We have the Civil Rights Act. We have a first Black president. We have women entering the workforce, right? We are trying to get people to be more tolerant, more open, less biased, more accepting of difference, less stigmatizing to people who are different in one way or another. And there's a view that, attitudes toward people being overweight or obese should be seen not in part through that lens of like stigma and prejudice and bias, but exclusively through that lens. And if you accept that, then yes, I mean, this is the American Academy of Pediatrics accepting that overweightness in children is bad. And if someone is I don't know how to put it, an asshole, a bully, right, who is being mean to overweight classmates or to overweight children who are entrusted to their care, you could now see the American Academy of Pediatrics as giving a kind of official imprimatur to this. Like, you're not being biased, you're not being an asshole, you're not being mean. We have official medical science that says it's true, that it's bad for these kids to be so overweight. And so this is going to make all kinds of problems worse. That's not a crazy concern, but what I do think is crazy is the view that bias and stigma is the only issue in this space.
Right. This is where we want to be clear. You and I have talked about this for years. We did an episode previously on weight loss medication and surgery and its benefits. And, we've questioned, why has the coverage not been more front and center of these medical breakthroughs? I'd say in the recent months since we did that episode, that has started to shift a bit. We're seeing coverage of these drugs more regularly, et cetera. Where I want to draw a distinction is that I don't disagree that people who are overweight are discriminated against. We know this. It's been studied. It's been shown. It's been shown in the workplace, in just everyday life situations, that this is well documented, and it's terrible and it's wrong. But where I disagree is in whether or not that is the only problem with obesity. And where I land on this is around what the Pediatricians of America are saying, which is that you have to assess a child's BMI, and that's an indicator. It's not the be all end all, which is another point that you kind of see, that this pushback against BMI as a tool, or I should say, I think it's often misrepresented that BMI is somehow taken in isolation. But regardless, the Pediatricians of America are saying, okay, if you have a child whose BMI is way too high, there's a list of things you need to do. And they provide this list. And one of them is to see, is there an underlying condition? What's going on in this child's life? And then the list gets more and more specific based on the child's age and other factors of making sure you're screening for adjacent comorbidities like high blood pressure, diabetes. In adolescent girls, are they showing signs of polycystic ovaries? That these are all things that are linked to obesity that could have a lifelong effect on a child. And so it is not, I think that one problem I have with this op-ed is that it does not genuinely interact or consider the evidence that's being put forward, or the actual steps that are being put forward, that the Pediatricians of America aren't saying, okay, sit a child down and say, you're fat, lose some weight. They're saying, you have a serious health condition and we need to make sure that you're healthy, and we need to start putting down markers now about your breathing, your blood pressure, and we need to monitor these things because we want you to lead a healthy, full life. So I think that's really my issue with it, is just the way that this article is written. And one point in particular that she makes, she points to a study that was done where a group of children were given bariatric surgery. It was done in a foreign country, and they looked at these kids. It was Swedish teenagers. And so she says in this study, 25% of the patients required additional surgery to resolve complications from the first procedure. And then 72% of all the children reported nutritional deficiencies. And so she's saying this is very risky, that we shouldn't put children through this because look at the evidence. But if you click through and look at the evidence, this study was done well before the normalization of different types of surgeries, that this surgery that these children had removed some of their gut, which is no longer the standard of care. But the standard of care is really much more likely to do a gastric sleeve procedure. You've talked about an even more or an even less invasive procedure that what it's doing is resetting the patient's metabolism and metabolic state. It's not removing part of the intestine, which is what causes major complications and can lead to nutritional deficiencies. So by saying, hey, we shouldn't put children up for surgery, she's not actually pointing to the actual surgery that we're even talking about. And that's where I have a problem, that, if you're going to make your case, but don't point to surgery that no one is suggesting that children have. It's been largely pushed out for any patient, that is not what the first line of defense is, and not what we're talking about.
Yeah, I mean, I would say that the sort of general issue with this argument is that it's a real kitchen sink kind of take, right? In which, she's raising all these sort of scare stories about treatments, but then also trying to say that there is no obesity problem, also trying to pick at the BMI metric. And it's like, actually needs to zero in, I think, on the core disagreement, right? Which is that she believes it's not true that the rising rate of childhood obesity is a problem.
Right.
I think that, if you think that it is a problem, which is what the American Academy of Pediatrics has believed that it's a problem for a long time, I believe. Like that's not what's new in these guidelines, right? If you want to understand the news, right? The news is that the AAP is shifting from childhood obesity is a problem and we need to do more scolding about people's diets, to childhood obesity is a problem and we need to start using medical treatments that are available, in particular, new prescription drugs and sort of new generation surgeries. That's what is changing in the AAP guidelines. And I think just as we talked about in the sort of original version of this, a lot of people who have sort of positioned themselves as critics of diet culture are looking at these kind of new treatments and new medical guidelines, and they are against them too. But there's actually a lot of overlap, right, in what these two camps are saying. I've been paying attention to a kind of people invested in diet culture, right? Like lifestyle influencers, like seed oil paranoiacs, keto diet promoters, all these people. Like, what's their take on these guidelines? They are also very hostile to the new guidelines because what they see is the American medical establishment moving away from the wisdom of the diet industry, which is that you need to buy this particular book, and go keto or go paleo or go Whole30.
Sure. It's a good grift. It's billions.
I mean, I'm not even, to not be like hyper stigmatizing, but I think that like people need to understand the state of the landscape, right? And that if you perceive yourself to be a diet culture critic, right, a skeptic of diet promoters, et cetera, that those people see anti-obesity medicine as their enemy, and they dislike this kind of new twist in the guidelines. Now, what's also true, though, is that if you come to this from the perspective of, so I would say there's a kind of like a soft fat acceptance, right, which is grounded in skepticism of diet culture. You say, look, all this past 30 years of sort of giving people a hard time about what they're eating has not been working as a society. It has caused people a lot of stress, a lot of anxiety, a lot of shame, a lot of bad feeling, but it has not like reversed the obesity trends. So the best thing that we can do is try to help people feel more relaxed. That's like soft fat acceptance. But then there's like hard fat acceptance, is to say this is all fake, right? Like it's not true that there are health risks associated with becoming hardcore overweight. If you believe that, then new medical breakthroughs aren't exciting because they're treating a fake problem. But the evidence for that is just really bad. You know what I mean? Like the case against diet culture is pretty strong, right? Like the case that people have made a lot of money selling books, selling weight loss plans, et cetera, that have terrible adherence and terrible results. Like that's really, really strong. There's a strong case to be made there. But the case that, like, factually speaking, people with high BMIs over 30 have all kinds of health problems is also really, really strong. And then I think it becomes important to engage with the specifics of, like, do these treatments work? I think that, the evidence base for bariatric surgery in children is fairly thin at this point. The nature of any new medical intervention is that, to develop strong evidence, you have to try it. And it has to be tried in circumstances where the evidence is a little bit thin. I think that's why the AAP is sort of hesitant to go that far. But the evidence on the drugs seems clearer. The risks are smaller, and they are trying to say, look, we need to move off of just sort of telling people, it would be better to, like, not eat Fritos and just eat fresh vegetables all the time. Because I think I got some feedback on our last episode about this, where people were like, come on, Matt, like, of course diet and exercise work for weight loss. And there's a level on which that's true. But what I think is also true is that, like, on a policy level, just like reiterating to people that it would be better to not eat junk food and that they should be eating fresh vegetables instead has not been efficacious. Like, and I think people are actually aware of this information. Right. Like, that's not the issue.
Well, I don't know that. So let's pause. So I think that you're right that individual people say, well, I lost 10 pounds doing whatever I did, or maybe they lost an even more significant amount of weight. But when you zoom out and you look at the entire population, this hasn't worked. So there's this temptation to go back to, well, this is an individual problem. And if you can't lose weight, you are a weak person and, you're a bad person. And all that leads to shame, where, it's this idea that if you're overweight, it's because you do not have impulse control. You are, and in terms of children, it's you are a bad parent who has done a bad job raising your child, instead of, okay, other diseases, we don't look at them and go, willpower. We look at them and think, okay, well, what's causing this? And how do we solve this problem at a national level? What could be done at a much higher level? What I think that these new guidelines are getting at is an acceptance, trying to get doctors to see that there are a lot of factors that play into obesity. I thought that the introduction was really profound about how obesity is associated with experiences of poverty, of racial stigmatization, that these sort of life experiences really matter. And there's a reason why we're seeing certain groups of children disproportionately affected rather than other groups. And this is not the way most doctors are taught to think about obesity. In fact, it's not part of most medical school curriculum. I mean, this is the number one, I think it's the number one leading cause of preventable death in the United States, that is linked to all of these diseases. And yet medical school is just not training doctors to understand it, to treat it with new evidence. And you can see that you see some emerging things happening. Harvard and Johns Hopkins have announced trainings for doctors. There's a movement toward, education, getting doctors to understand that there's this new approach to obesity. And that's really important because that's how you implement policy. We've had essentially, the CDC, we've talked about this before, their website says, eat less, exercise more. And that's what doctors have been telling people. Well, that's that. So essentially that's the policy, is have doctors tell patients to eat less and exercise more. And I know this is frustrating to listeners. I've heard this too, which is when you look at aggregate level and big populations, that it doesn't work. I mean, there's the famous Biggest Loser study where most of those contestants gained all the way back and even more. And there's a look at why and how these people who lost all that weight were gaining it back because their caloric needs, were higher, their hormones were different, and it's the starting point of, instead of blaming an individual, looking at a problem as a national policy problem.
Well, so, this is also where I wanted to say part of what I thought was, weak about this op-ed is that after all this kind of big rhetoric, right? The new obesity guidelines terrify me, all these terrible things. When she gets to what we should do, right? She says, what should the obesity guidelines say instead? Stop classifying kids and their health by body sizes altogether. This would involve a paradigm shift to weight-inclusive approaches, which see weight change as a possible symptom of or a contributing factor toward a larger health concern or trouble or struggle.
That's what the guidelines do. Like, read the guidelines.
Right. That's I mean, we're now really splitting hairs about the exact sort of verbiage, right? And she also has this move earlier in the piece where she talks about body mass index and its sort of limits as a measurement. And that's a kind of a stock item in the anti-obesity arsenal. And it's a little bit... It's a weak point, right? I mean, like, here's the deal with BMI. The reason that clinicians like BMI as a screening metric is that it's something that you can calculate very easily at home yourself without any special equipment, right? To calculate your BMI, you need to know your weight and you need to know your height. You plug them into a formula. The formula gives you certain results. Now, is BMI a perfect index of metabolic health? Like, definitely not. And none of the people putting guidelines out about BMI believe that it's a perfect index of metabolic health. What they believe is that more sophisticated measurements are more technically complicated and are harder to do, right? Like, you can't at home check your body fat measurement in a super reliable way. We now have new scales that can give you a rough estimate by running electric currents, but to get a really, really good measure of your body fat percentage, you need a sort of complicated measurement. To get a really solid measurement of your basal metabolic rate, you need more complicated equipment. But this is just the same, like, all kinds of health problems have this characteristic, right? Where there's the simple at-home screening that you can do for yourself, right? Like, did my eye turn red, right? Like, if your eye turned red, that is probably an indication of some problems. And then you might need to go into the doctor and get some more advanced tests.
Right. And you should go to the doctor. And it might turn out that your eye is red because something got in it and now it's fine. Might be nothing, but it could be something.
And somebody, look, you might have a BMI that is a little bit above the obesity threshold because you're unusually muscular or because you have unusual amounts of bone density. Like, there are exceptions to this rule, but like, the doctors who are putting these guidelines out, they are aware of those facts, right? Like, they are not saying, go at home with a simple scale and a ruler, take your BMI, and then just like treat that as the absolute gospel truth and never check any other aspects of your health. Like, that would genuinely be crazy. What they are saying, though, is that people with high BMIs probably are going to have these other problems, right? Like you could get it checked. You could do more sophisticated tests. And so, it becomes this kind of straw man. And she's at the end, she's like, well, it could be a symptom of or a contributing factor to a larger health concern. But like, yes, like exactly. Right? Like it is a contributing factor to heart disease and other kinds of problems.
Well, I would say, Matt, I think it's worth thinking about the guidelines specifically, which is BMI is the starting point. So you're a doctor, you have a patient, you look at their BMI and say it's really high. Does she really think that a doctor is stupid enough to sit there and be like, wow, this kid is like on the high school swim team and he's really ripped? Got to get him bariatric surgery? No, it's okay. In this case, his BMI is whatever. It's high, but clearly he's athletic. And, then you have the tree of what to measure and what to keep track of. And versus a kid who comes in who is very high at BMI, and you kind of look at the patient and think, okay, this, why, let's explore further. And there's a list of things to do, which is to assess lung capacity and breathing. I think blood pressure probably is for all patients, but blood pressure, there's sort of a list of things. Screening for diabetes, starting that process of, okay, this child's BMI is high. What else could be going on here? And you create a record and you have a starting point. No one is saying, like, I mean, what doctor is going to say, like, oh, your BMI is low and I'm not going to inquire at all, like, even see
BMI 31, let's go get surgery without checking anything else. Like that's stupid.
Yeah, like we'll just send them off. Or, oh good, your BMI is so low that it's at the bottom end of the scale and I'm looking at you and they're like, that's great. Like you're weak. And like, I mean, like, no, any doctor is going to look. I mean, in terms of weight, like she also mentioned sudden weight loss. And I don't think my sister would mind mentioning, my nephew. He's 9 years old. He's a tall kid and he's been growing like a weed, but she was very concerned about his weight because he was losing weight. And she took him, which is not standard for a 9-year-old, and she took him into the doctor and he has type 1 diabetes because she was concerned about his weight. And the doctor said, I'm glad you brought him in. This is, weight loss is a symptom of something. And the doctor wasn't like, oh, good, his BMI is low, send him home. It was,
right.
His BMI is too low. This isn't right. What's going on? And she investigated further and concluded that, he had a problem. And I think the BMI thing is something that comes up a lot in this of, oh, it's a bad measure of, maybe you're not. I also think it's this idea of where the obesity line should be. And I think that's what comes up a lot too. And I have this conversation more with adults of, I'm told I'm obese, but I don't think I'm obese given my height and weight. I think that I'm the right size for me. And I think that gets just into semantics that, okay, if, you're, and I inquired further with my friend who was really upset about this. And she said, her BMI is whatever it is. I don't actually know. But her doctor said, you need to lose some weight. And what bothered her was that of just, you need to lose some weight. Because it was like, well, I can't, I work out 3 times a week. She's a very healthy eater who lives in California and shops at a farmer's market. Like for her to lose 10 pounds just seems like it just doesn't seem realistic, to me or to her. And so this is where it also gets back to education for doctors, that just telling people to lose weight in and of itself, one, that's hard to do. And 2, talking with a patient about why, are there other concerns going on here that your weight may be associated with, instead of just sort of in isolation talking about your weight, which is something that I think is being said in this op-ed of weight in isolation is just bullying. And I can see how it would feel that way. I went to a doctor once who told me to lose 10 pounds because my back was hurting. And at the time, I don't know, I'm 5'7", 5'8", and I weighed, I don't know, 136 pounds. And like for me to lose 10 pounds is stupid. Like that's just not going to work. Also, there was no evidence that losing weight would help your back. But I think that there are these individual stories of dealing with doctors and weight that can drive you crazy. And I get that, but that's not what we're talking about. We're actually trying to solve that problem. And rather than saying, I'm going to give up, like we should give up on the medical system. They're just going to be a bunch of bullies. Let's give up on them. Let's just live over here where we don't attempt to solve any of these problems. We're just going to say it's fine, is really frustrating to me when there is a medical breakthrough that's saying, hey, maybe, we admit that we've been wrong and there's something else we need to consider here. And that's what drives me nuts about kind of these types of op-eds.
In our earlier podcast on this, I was very jazzed up about medical interventions for obesity and said they should be getting more attention. And I'm glad that they have been getting more attention. And I only wish the Novo Nordisk sponsorship had come in of my dreams.
Yeah, bad takes. Brought to you by Wegovy.
The thing though that does give me some pause here is the individualized nature of the conversation that is now sort of launching. One of the big public health success stories of the past 50 years has been getting people to smoke less, right? And some of that has been just kind of like informing people about the health risks of heavy cigarette consumption. And some of that has been promoting like tips and tricks for how to quit smoking. And some of that has been developing medical interventions that help people quit smoking, things like nicotine patch, nicotine gum, stuff like that. But a big, big, big part of the Stop Smoking campaign and the Stop Smoking campaign effort's success has been collective public policy change, right? So I used to be a heavy smoker and I quit. And like most people who successfully quit smoking, it was a little bit of a stop and start thing. There were a couple of times when I had quit smoking and then I went back to it. And even my sort of final quitting of smoking, if you were to do the chart, there were a couple backsliding moments on the road to success there. So that's similar, I think, to the struggles that people have with diet and exercise as a weight loss technique, right? Like, everybody knows lots of people who have gone on diets and lost weight. We also just know that the majority of those people end up backsliding. For a long time, cigarette nicotine addiction is not totally different from that. But we have actually had a lot of success in getting people to permanently give up smoking. And now some of that is like the Nicorette gum really, really helps with quitting smoking. And one way that I found that it helped is that it helps it relieves some of the physical symptoms of nicotine withdrawal, but it also helps remove an excuse, right? To be like, oh shit, I have this deadline at work. I have to get this done. I cannot be sitting here having paralyzing cigarette cravings, right? But you can, if you're in the committed mindset, you can go get your Nicorette, right? And take that and get some relief and not go back to smoking. So that's great, right? The information part is great. The scolding part is great. The medical interventions part are great. I know some people had success with Wellbutrin, other things like that. But ultimately, for me, and I think for a lot of people who quit smoking, what really kind of shoved us out the door on there is that, the range of places in which you are allowed to smoke kept getting narrower and narrower, right? I remember one time, feeling like I'm a pathetic addict because I am standing out trying to take shelter from a hurricane, literally a hurricane, so that I can go outside and smoke a cigarette.
Yeah, that's a look at your life moment. You know, if I would show up to an event, I don't remember you specifically, but I remember just this really specific moment where we have a friend who has an identical twin brother, which I was not aware of as I was approaching this this bar establishment, and there was this guy huddled outside. Is that anyway, nonetheless, it was weird, but it was so cold out, and I remember, like, totally judging my friend, which turned out to be his twin brother, like, "Man, get inside," but, you know, he's having a cigarette. What was he gonna do? And yeah, it's the social isolation, I think that was a big part of it, you know, I think that's been measured even of just when you're isolated like that, your behavior feels, you know, I like social it's running against the grain of social norms that I think probably for you, smoking was social at some point, right? That it was something you did in a group, maybe? I don't know.
Well, exactly. And, when I had my friends who were, originally, like in high school, I would go out on the corner where the smoking kids smoked and we would all smoke together and we were like pals, and then I would get up and, you do it in bars. I wrote a book at Sparky's Cafe on 14th Street at a time when you were allowed to smoke in coffee shops and bars in DC. The back room was the smoking section. And like, and some other writers who lived in the neighborhood who were smokers.
I remember the smoking indoors, in my hair, in my clothes. I was never a smoker. I guess I smoked cigarettes for a while in college because it was cool, and then it was like, "This makes me feel like crap, and I'm broke. It's too expensive for me."
Well, this was the sort of duality of the anti-smoking campaign, because the sort of official reason for banning smoking, first in restaurants, then in bars and coffee shops, I mean, it was banned in airplanes, all kinds of places, was to sort of help non-smokers.
Right.
Right. So that you would no longer need to deal with the nuisance of me smoking. But that was very efficacious in getting people to smoke less. And something that I think is interesting about it is that if you took the other thing is that, I mean, if you remember politics in the 1990s and early zeros, anti-smoking was considered a progressive cause, right? Bill Clinton was taking on big tobacco, right, with these anti-smoking regulations. I think that if you took contemporary progressive values and you transported them back to the time when there was the big crackdown on smoking, people would say, well, we're really stigmatizing smokers, and that's bad. And I think we were stigmatizing smokers. Like, I felt stigmatized. One time I had a connecting flight in Chicago, and I couldn't sit there for 90 minutes and wait for my next flight, having not been able to smoke while I was flying out there, and I wasn't going to be able to smoke on the other flight. I was like, I need to go outside the security perimeter, outside, smoke 2 cigarettes, and get back in. And then there was a really long security line, and I almost missed my flight. And I felt so dumb. But the reason that whole thing arose was that there wasn't an indoor smoking section in O'Hare, right? They deliberately moved to make life less convenient for smokers. They moved to not accommodate our needs. And that helped sort of push people into not smoking. And I think that ultimately, right, the solution to unhealthy diets is not going to be, well, we're going to have kids have very unhealthy diets, and then we're going to put them on Wegovy to sort of redress that, right? You need prevention in terms of what kind of food is available and what kind of food is not available. And that's going to mean collective action. And I think it's ultimately going to mean stuff that is tough, stuff that is a little mean.
I think it's also worth noting that this is not a silver bullet, in that you don't have bariatric surgery or start taking these drugs and then it's a free for you can eat whatever you want and not lose and not gain weight. It is an opportunity to reset, lose weight, and hopefully your your gut health, your hormonal, your hunger hormones are reset. But, these kids are going to need to change their lifestyles forever. And it's, what environment are we going to put people back into? And just giving people drugs is not enough, that you're going to need what you're talking about here, which is a huge shift in how we live our lives.
It's been interesting watching kind of ideological drift, right? Like when Michelle Obama was promoting, I would say like very modest lifestyle interventions to try to address childhood obesity. Conservatives like really freaked out. You know what I mean? It was like a freedom question for them. Now that like fat acceptance and skepticism of diet culture have become more prominent on the left, there's been some negative polarization. And now conservatives, I see like talking a lot about different diets and lifestyle changes and, just lift bro and all kinds of stuff like that. But that I just still feel like leaves us circling the drain, right? That like, so something I've been looking into recently, there was in the mid 20th century in the United States, there was a big push to try to eliminate hunger as a problem in the United States of America, right? And this goes back to the Truman administration and Richard Russell. It continues through. There was like in the late 50s, Congress passed a law to like allow the president to create a food stamp program, and Eisenhower wouldn't do it. And then when Kennedy was president, one of the first things he did in 1961 was use this executive authority. Lyndon Johnson expanded it. Richard Nixon in 1969 held the first White House conference on nutrition. And what the subject of a 1969 conference on nutrition wasn't obesity, it was hunger. And, he said that we need to end hunger permanently in the United States of America. We haven't literally ended hunger. Like there's a lot of people in the United States and, situations vary, but we have very substantially achieved that goal to the point where like the food insecurity definition that people use just like sets a higher bar than the one that people were using in the mid 60s, right? We're setting sort of higher aspirations for ourselves. And like, that's good. But the point is that like all of that was a collective endeavor. We were creating programs that were designed to ensure that people were able to meet certain kinds of minimum caloric standards, just as we then had a collective effort to get fewer people to smoke. And ultimately, like these, weight loss medical treatments are, I think, a really good, really useful backstop that can help a lot of people. But what we're going to want is like a serious look at what kinds of policy measures can be effective for prevention. And I think there's going to be a lot of optimism that like there was this program I think the Obama administration did to like get farmers markets to accept food stamps. Right. And it would be great to think that we could solve these problems purely through like push measures, right? To say like, here, kids, is some lovely broccoli, just enjoy it. And I just think that is not realistic. Like ultimately, we're going to need to do things to make chips and soda and, white bread, just like high calorie, low nutrition foods less available, because we are now not a country in which large numbers of people need to worry about starvation and like need access to that stuff. But we struggle. I mean, we struggled to crack down on selling tobacco. We struggle with alcohol, and we struggle with junk food.
I think the junk food thing, the price of eggs has become kind of a meme. My partner was at the grocery store recently, and he and an elderly woman were kind of, oh man, eggs, these prices, and he was sort of, for him, for me, for us, eggs double in price, we can still buy eggs. This elderly woman, she just didn't buy eggs. She walked away. And for her, eggs are the cheapest protein that she can buy, like quality protein. I don't know what she went and bought instead. But on her fixed income, she could no longer afford eggs. Presumably, she bought, more starch or something, because you're not going to go buy some other protein that's cheaper. So it's not just, it's the problem is, yes, hunger has been, we've made a huge dent, but when you're talking about being, low income and buying food, the healthier food is more expensive. And so you've got that problem. But in terms of your point about push, you can push vegetables and you can push, a salad bar for kids at school. But, it's not just, at the end of the day, it's not just what you eat, it's what you what you do eat. It's, you got to eliminate high calorie junk, and it's everywhere, and it's so cheap, and it's so prominently displayed. You walk into Walmart and it's just these pyramids of very beautiful looking, tempting, plastic tubs full of cupcakes and stuff that are very cheap, and frankly, they're delicious. And it's when you're on a fixed income, it's like, well, I can afford to add this treat to my basket. And it's not just the push, right? And I don't know what political willpower there would be to tell grocery stores you're not allowed to put high calorie foods like front and center. Like, what, like, you have to put them behind a locked vault? Like, what, like, how would you possibly do that?
I think, it's important to be clear, because I think people can get sort of woolly headed about this stuff, about prices, right? And what is definitely true is that healthy foods have a sort of higher relative price compared to sort of junky foods, and that's an issue with nutrition. What I think is like probably not true is that like just subsidizing healthy foods doesn't like get you out of the woods.
Oh yeah, because see, let's just be real. Junk food is good. It tastes good. It's like addictive. You can't eat just one chip.
Right, because people like it. And I also think in some ways the conversation overly focuses on like low status foods. Like, one of the biggest changes over the course of my lifetime is just that like food in America has gotten way better. Right? Like, not just like junk food and stuff like that. But, when I was a kid in New York City, like a Thai restaurant was a sort of exotic offering that we had in the big city. And like these days, like you can get pretty good Thai food in Blue Hill, Maine. There's pretty good sushi in Kerrville, Texas. Like we've just like made incredible strides in having tasty food, a range of tasty foods from different kinds of ethnic cuisines at restaurants. There's more different stuff in grocery stores. Like, we never had avocados in the Northeast when I was a kid. I'm sure you did in Southern California.
I was going to say avocados. We did not, my mom wasn't, we weren't going around buying, those were like $5. And then post NAFTA, they're cheap.
And to be clear, like as far as I know, avocados are healthy, but it's just all kinds of stuff. We have out of season berries now, right? That are flown in from Chile. Like, we just like have gotten much better as a society at like producing and manufacturing and distributing food, which is mostly good. Like, it's not just that hunger and malnourishment have declined. Like, life is more enjoyable. If we had to go back to the culinary landscape of 1973, I think people would actually find that pretty upsetting, in terms of their personal life and the quality of things that are available. But it has this downside, right? That like, if food becomes more affordable, if it becomes accessible at more times of day, if a wider range of things become available, it's just the odds at any given time that you're not going to be able to find something that's like really yummy have declined a lot in a way that's really at odds with the bulk of human experience, and it's creating problems. A collective solution to them would be very politically difficult. But I mean, again, to go to the smoking analogy, right? If you look at the history of anti-smoking initiatives, it starts with like the most mild thing imaginable, which is the Surgeon General just like officially says, smoking is bad for you. You shouldn't do it, right? And then it goes to, it says it on the the packs of cigarettes. Like, smoking is bad for you. You shouldn't do it.
So I get your analogy with smoking. The issue with smoking is no amount of smoking is good for you, and it is addictive. There is an amount of food that is good for you and, in fact, necessary. And
it's important to eat every day.
It's not saying you need to stop doing a behavior and we're going to stamp it out. It's okay, we need to keep these behaviors, but moderate them. The other thing is that there was a villain in the tobacco story, right? Like gotta stamp out big tobacco. But in the food realm, it's not there is big agra, of course, that could be, I suppose, a villain, but the issue would be what are we saying here? Stamp out the local taco stand. I mean, like, it's not there's not. Yeah, war on tacos. I mean, it isn't.
War on tacos, yeah.
It's not the same. It's a much more complicated issue. And, you can also become overweight eating, air quote, healthy foods. If you're eating tons of nuts, if you're eating granola bars, avocados, sure, have a slice of avocado. But if you're eating lots of avocados all day, it's a and you're smearing it on toast, like, hey, that's not necessarily going to keep you thin.
I'm getting into the speculative terrain, but like, obviously, like, biophysically, you could eat a lot of avocados every day and get really overweight that way.
Well, but the thing is, you're going to eat them with chips.
Well, right. But I mean, this is my question, is like, does anyone actually do that? Or is it the chips and the toast and things like that get people there? Anyway, I don't know. Here's where, like, I am out of my depth and I don't want to offer a super duper strong take, but it is just my concern about the enthusiasm for I share the enthusiasm for new generation weight loss treatments, but I also do think that as a society, we need to think about prevention and collective action and the way we treat, a comprehensive look at food, at alcohol, at tobacco, at marijuana, right? At this whole range of things that exist out there that I don't think, should be illegal, but that do need to be regulated, that need to be taxed, that need to be managed. And the food situation is nuanced and complicated because, we tax alcohol to sort of try to discourage overconsumption. But there's no problem. No one's like, oh my God, like, this person like can't afford beer. Like, that's okay, right? Whereas, like, people being unable to afford food is really, really bad. So you need a mix of, like, subsidy and taxes, regulations. We give kids food in school so that they don't go home hungry. So we need to look hard at, like, well, what is that food? It's a difficult issue. But, like, precisely because it's not totally obvious what you should do about it, like, I think we need to have a serious conversation that isn't just pharmaceutical lobbying versus this kind of, like, anti-science, like, it doesn't matter how fat kids get mindset.
Yeah, throw your hands in the air and this is all made up. I agree with all that. I think I agree with that. Before we wrap up, I think one note we didn't get as much into as I wanted is we have pretty good research on obesity, drugs, and procedures for adults. This is, I will say, when you start to look at changes in treatment for children, that's a big deal. If you're putting forward the idea of giving kids powerful drugs and surgery, I understand that as a real concern and conversation, but that's not what happened here in the op-ed that we saw in front of us. So I think it is fair to be wary whenever in the United States there's a new drug that people get excited about and overprescribing. That's something to consider. But I also just don't think we're there. But I do think there could have been a debate about something serious. but that's not what happened.
No, I agree. Not a great take. And I think that it is. It's doing a disservice to I think a topic with like genuine uncertainty. It does a disservice to it to introduce like totally fake considerations. Like maybe there's just no problem with people becoming overweight. Like that's not right. I think there are a lot of questions about like what will actually be efficacious or worthwhile or feasible and lots of other things in that area. And, we should like promote kindness and like discourage bullying and all that kind of stuff. But it's a really unhelpful distraction to need to be like refighting the absolute most basic factual elements constantly.
Agreed.
All right. Well, that's a wrap. This has been another episode of Bad Takes from Grid. We are produced as usual by Paul Woodhull, and we will be back next week with more Bad Takes.